Hello friends, I am Dr. Shoaib Padaria from Mumbai, India, and today I shall be speaking on thrombosis in pregnancy. I have no conflicts of interest. Venous thromboembolism, which includes deep vein thrombosis and pulmonary embolism, is the third leading cardiovascular killer after heart attack and stroke. And VTE causes more people to die annually than breast cancer and AIDS combined. Pulmonary embolism accounts for 40% of non-fatal cases of VTE, while deep vein thrombosis is responsible for 60% of non-fatal cases. Pregnant women have a 4 to 5 times increased risk of symptomatic venous thromboembolism. There is an estimated incidence of 1 to 2 per thousand pregnancies. 85% of cases of DVT in pregnancy are in the left lower extremity. And in developed countries, pulmonary embolism is the leading cause of maternal mortality. The clinical presentation of both DVT and pulmonary embolism in the pregnant woman and in the non-pregnant women is more or less the same, and we all know about the signs and symptoms of these two conditions. There is, however, a significant change as far as the role of D-dimer test for suspected DVT is concerned. We know that in non-pregnant females, D-dimer test is a rapid and inexpensive method of diagnosis, useful for excluding DVT if the result is normal, and is a highly sensitive assay with only 4% false negative results. However, in pregnancy, the elevated levels of D-dimer are seen because of the physiological changes of pregnancy and also in preeclampsia. And therefore, D-dimer should not be used to definitely diagnose DVT in pregnancy. When you have a clinical suspicion of deep vein thrombosis, how do you proceed? If the clinical index of suspicion is low, then either you can do a D-dimer, which is not advisable, or you go straight away for an ultrasound of both lower limbs. If the ultrasound is negative, DVT is excluded. If the ultrasound is positive, then obviously DVT is present and you start anticoagulation. If your clinical index of suspicion is high for DVT in pregnancy, then you will still do an ultrasound. And even if the ultrasound is negative, you will start anticoagulation and repeat the ultrasound in 1 week's time. If the ultrasound is positive for thrombosis, obviously DVT is diagnosed and you start anticoagulation. What about pulmonary embolism? When the clinical index of suspicion is low, you can go straight for a spiral CT. If it's intermediate or high, again for a spiral CT. D-dimer is usually again not advised. If it's a normal spiral CT, pulmonary embolism is excluded. If it's an indeterminate result of a spiral CT, additional tests are required, such as a ventilation perfusion scan, an ultrasound, an MRI, or an angiogram. If the spiral CT is positive for PE is diagnosed, you start anticoagulation. In those centers where spiral CT is not available, then you would prefer to do a ventilation perfusion scan. What is the role of CT pulmonary angiography in suspected PE in pregnancy? It has some advantages over a ventilation perfusion scan. It has better sensitivity and specificity. There is lower radiation dose to the fetus and also helps to identify other pathologies such as an aortic dissection. On the other hand, there are certain disadvantages. There could be a high radiation dose to the maternal breasts, may not identify small pulmonary embolisms, and the iodinated contrast material may potentially alter the fetal or neonatal thyroid function. In pregnancy, what is the time period when VTE occurs? A meta-analysis has shown that 2/3 of cases of DVT occur antepartum and are distributed equally throughout all 3 trimesters. In contrast, 43 to 60% of pregnancy-related PE occurs 4 to 6 weeks postpartum. So a significant difference between the time period of DVT and pulmonary embolism. What is the duration of the postpartum risk? We know that the prothrombotic changes which are associated with pregnancy do not revert completely to normal until several weeks after delivery. And there is clinical data to suggest that an increased risk persists for up to 6 weeks postpartum. There are 3 questions which we need to answer. 1. Can we identify women who are at greatest risk of VTE? Secondly, who are the patients in whom we start prophylaxis? And lastly, is pregnancy-related VTE preventable? So the first question, can we identify women who are at greatest risk? And for this, we must address this question. Why does venous thrombosis occur in pregnancy? And there are 3 reasons. One is the physiological process of pregnancy. Secondly, the presence of inherited coagulopathy. And thirdly, the presence of acquired risk factors. What are the physiological changes in pregnancy? There's an increased level of procoagulant factors, factors 2, 7, 8, 10, and 12. There's a decreased serum level of protein C and protein S. And there is a decreased fibrinolytic state. This is because of an increased serum plasminogen activator inhibitor 1 called PI1 and placental activator inhibitor 2 called PI2. Then, of course, there's the presence of inherited coagulopathy. And the most common condition which we know is the factor V Leiden mutation heterozygote with a prevalence of 2.7 and an odds ratio of 9. Lastly, there are many acquired risk factors for coagulopathy in pregnancy. An age of the pregnant woman greater than 35 years, any operative delivery in pregnancy, especially cesarean section, blood group A, hypertension, postpartum bleeding, and a previous history of VTE which is unprovoked or during previous pregnancy, and last but not least, the oral contraceptive use. Now, a few words about inherited coagulopathy or thrombophilia. Thrombophilia is present in 20% to 50% of women who experience VTE during pregnancy, but with an associated risk factor. And there are 3 groups of patients. 1. Pregnant women with thrombophilia and previous VTE. Secondly, women with thrombophilia but no previous VTE but a family history of VTE. And thirdly, pregnant women with thrombophilia, no previous VTE and no family history. Here these differences are important because the guidelines for treatment are also different. For example, if there is a history of previous VTE event in a patient with thrombophilia, then you must give intrapartum and postpartum thromboprophylaxis for 6 weeks. If you have no previous VTE, with or without a family history of VTE, then a minimum of 7 days of thromboprophylaxis is usually recommended postpartum. And this duration postpartum can be extended to 6 weeks depending on the number of additional concomitant risk factors. There are certain other specific situations also. One is the presence of antiphospholipid antibody syndrome. This condition, commonly called APS, is an autoimmune disease present mostly in young women. Those with APS make abnormal proteins called antiphospholipid autoantibodies in the blood. And this can lead to dangerous clotting in arteries and veins. Antiphospholipid antibodies are present in 15% to 20% of all cases of DVT occurring in people under the age of 50. And they are also a major cause of recurrent miscarriages and pregnancy complications when no other causes are found. How do you manage these patients? If these patients with antiphospholipid syndrome have a history of thrombosis, then antenatal therapeutic dose of low molecular heparin has to be given until after delivery, and then you switch to oral anticoagulants. If the patient has already been on warfarin, convert to low molecular heparin as soon as possible. Patients who are not on anticoagulants should start LMWH as soon as possible in the first trimester and again should be continued for at least 6 weeks after delivery. If you only have autoantibodies and no history of thrombosis, then only low molecular heparin for 7 days postpartum is to be given. Caesarean delivery is an important risk factor for VTE. It carries an increased risk of VTE regardless or whether it is performed in the presence or the absence of labor. And if these patients have additional risk factors, then thromboprophylaxis has to be given to these patients. High body mass index and immobilization are other risk factors. Antepartum immobilization, which is defined as strict bed rest for at least 1 week, was the strongest risk factor for both antepartum and postpartum VTE. The effect of immobilization is modified by body mass index, which has a multiplicative effect. And we all know that obesity is a well-known risk factor for VTE, both in the general population and during pregnancy. How do you manage patients who are receiving long-term vitamin K antagonists? We know that warfarin readily crosses the placenta and has been associated with congenital malformation and fetal and neonatal bleeding. In such women who want to become pregnant, repeat pregnancy tests should be proposed and warfarin should be replaced by full dose LMWH when pregnancy is confirmed. How do you give anticoagulation in pregnancy? We must balance the risks and the benefits of anticoagulation. Most of us would start off by giving the patient unfractionated heparin with a loading dose of 80 units per kilogram per hour, followed by an infusion rate of 18 units per kilogram per hour. And the infusion rates of heparin are modified according to the results of APTT, and we maintain the APTT between 1.5 to 2.5. Low molecular weight heparin, however, is preferred to unfractionated heparin for several reasons. A better safety profile both for the fetus and the mother, potentially reduced risk of bleeding. Low molecular weight heparins are not associated with increased risk of severe post-peripartum bleeding. A significantly lower bone density is seen in patients receiving unfractionated heparin than in those receiving low molecular weight heparin. Heparin intolerance and heparin-induced thrombocytopenia are not seen with low molecular weight heparin. And we all know that anti-10A factor monitoring is not necessary during treatment of VT in pregnancy, and therefore LMWH is the preferred drug. Weight-adjusted dose of LMWH is to be given, and as far as enoxaparin is concerned, we know that we give 1 milligram per kilogram every 12 hours, or in the intermediate dose of 1.5 milligrams per kilogram once a day. So what is this intermediate dose therapy of low molecular weight heparin? This ranges from 50 to 75% of the full treatment dose. Gray et al. From the UK suggest a full dose of minimum of 1 month before reducing to an intermediate dose of LMWH in the absence of additional risk factors such as underlying thrombophilia, immobility, and obesity, and this is also backed by the ACCP recommendations. What about other anticoagulants, such as, for example, pentasaccharides like fondaparinux? As per ACCP guidelines, the available evidence for efficacy is low and should be avoided. What about NOACs? There is as yet insufficient data regarding safety in pregnant women. What is the duration of treatment of VTE in pregnancy? A minimum of 3 months of anticoagulation proposed for secondary VTE. 6 months of anticoagulation should be considered for idiopathic VTE. But treatment should be continued during the remainder of pregnancy and for at least 6 weeks postpartum. Importantly, mobilization with graduated elastic stockings, at least class 2, should be encouraged to reduce the pain and swelling, and also to reduce the risk of post-thrombotic syndrome for 2 years after the occurrence of VTE. Which anticoagulant can be used in the nursing women? A question commonly asked by patients. As far as warfarin is concerned, there are many reports which confirm the absence of detection in breast milk and the anticoagulant effect of warfarin in breastfed infants. And so the answer is yes, it can be safely used. As far as unfractionated heparin is concerned, because of its high molecular weight and strong negative charge, it does not pass into the breast milk. So the answer is yes, it can be used. And low molecular weight heparin, small amounts of LMWH were found in breast milk. However, due to the low bioavailability of orally ingested LMWH, a clinically relevant effect on the nursing infant is unlikely, and so the answer is yes. So you can use warfarin, unfractionated heparin, and low molecular weight heparin, all of them in nursing women. How do you manage anticoagulant therapy at the time of delivery of the baby? ACCP recommendations advise stopping anticoagulation 24 to 36 hours before elective induction of labor or cesarean section. However, if the patient is considered to be at high risk, it is important to minimize the time of anticoagulation. In such cases, replace LMWH by intravenous unfractionated heparin, which because of a shorter half-life can be discontinued as and when required. If spontaneous labor occurs, careful monitoring with PTT is required, and protamine sulfate may be occasionally required to reduce the risk of bleeding. When do you restart anticoagulation after delivery? Low molecular weight heparin should be restarted as soon as it is safe to do so, usually within 12 hours of delivery, and warfarin can also be started at the same time. A thromboprophylactic dose of LMWH should be given by 3 hours post-operatively and more than 4 hours after the removal of the epidural catheter if appropriate. How do you prevent VTE in the postpartum period? In these following cases, 7 days of low molecular weight heparin should be given post-delivery. Which are these cases? Obese women with BMI greater than 40, prolonged labor, immobility, presence of infection, presence of hemorrhage requiring blood transfusion, emergency cesarean section, or an elective cesarean section with more than one of the above risk factors. Finally, we must not forget the role of early mobilization and role of compression stockings. We know that early mobilization does not increase the progression of VTE. There is no need for bed rest in a stable patient on anticoagulation for VTE. We all know that pain and swelling improve much faster with mobilization and also helps in preventing development of the post-thrombotic syndrome. As far as compression stockings are concerned, class 2 compression stockings are to be used. They are not to be worn at night. Thigh length stockings for thigh swelling, below knee stockings for below knee swelling, and not to wear on the unaffected leg, and should be worn for at least 3 months post DVT, preferably for up to 2 years. I thank you very much for your attention.